All right, so last week we spoke about organophosphates more than anything. All right. So this week, what we're going to do is we're going to concentrate and see how far we can get. But the first thing we're going to talk about is the opposite of organophosphates, yeah? Anticholinergics. All right. Oh, okay. Just wait for a second. All right. So you remember from last week what we spoke about? Okay. So organophosphates we kind of all know, right? Small pupils, hypersalivation, lacrimation, diaphoresis, urination, defecation, hypothermic, bradycardia, altered mental state. So anticholinergics, all right. Atropine is not very common because sorry. Oh, okay. No, sorry. Okay. So, right. So just to recap for those who came in. So today we're carrying on with toxicology. Can you see it? All right. So as we were saying, we all know organophosphates, all right, or cholinergics, all right, which we had kind of covered, all right, small pupils, that whole list, all right. So today we're going to talk more, well, we'll see how far we get, but we're going to start talking about more the anticholinergics or TCAs, tricyclic antidepressants. Okay, so we had one this week. I don't know if you were here when she came in. I don't know, were you here? She came in during the week. I know the person was with me, and who else was with me? I think Masilela was with me, right? So the thing is, tricyclic antidepressants, the most common is amitriptyline, okay? And as we said, amitriptyline is given out readily at most of our hospitals, okay? So tricyclic antidepressant, amitriptyline overdose is quite common, surprisingly, and it is lethal, so you do have to be worried. So basically, for anticholinergics, if you can remember this list for organophosphates, you don't have to remember this list because it's the complete opposite. Okay, but this is exactly what you see. Dilated pupils, dry mucous membranes, dry eyes, dry flushed skin, urine retention, constipation, hyperthermic, tachycardic, right? So that patient that we had, well, she overdosed on three things. She overdosed on calcium channel blockers, amlodipine. She overdosed on TCAs. She overdosed also on proton pump inhibitors and things like that. So she went to ICU. But in any case, she had quite a few of these. So specifically, the urine retention. We put a catheter in, but we still had to force the urine out of her because the bladder becomes basically a neurogenic bladder. Okay, so we had seen this. I'd shown it to you all the last time, all right? So this is cholinergic or organophosphates, and this is anticholinergic. Okay, so that's basically how you try and remember them. Okay, but this is exactly what it is. Mad as a hatter because they are absolutely confused. They don't know what's happening. Dilated pupils, dry mouth, urine retention, shaking, grabbing invisible objects. I must be honest, I haven't really taken note of it before, but I assume that they do that. Tachycardia is quite common, right? And we're actually going to concentrate a little bit on that tachycardia in a little while. Okay. So we're just going to skip through this. We went through the management of organophosphates. All right. So what about the management of the question is, how do you manage anticholinergic poisoning? And in fact, how do you manage a lot of poisonings when you're not sure? Is sodium bicarbonate. Okay. Now, there's a few reasons why you give sodium bicarbonate for a lot of these patients. Number one, you're alkalinizing the bloodstream and you're alkalinizing the urine, which helps for illumination. Okay. And number two, specifically with anticholinergics, one of the problems that they have is that they affect the sodium channels of the heart, which we'll get to just now, right? So you're actually providing a large amount of sodium. Ideally, you want to give physostigmine, all right? But physostigmine is not readily available. You do find it in the ICU settings, and if you can get hold of it, you give it. But sometimes you're not sure of what you're going to do, whether you are treating a TCA, whether you're treating this, whether you're treating that. So physostigmine is quite specific. Okay, and if you are going to give it, you must make sure definitely I'm treating an anticholinergic syndrome, right, or toxidrome. So the more common one to use is sodium bicarbonate. Okay, so sodium bicarbonate, the way that you work it out, you're giving 1 to 2 milliequals per kilogram. Doesn't make sense, eh? So the easiest way to remember it, 8.5% sodobin, all right? For every ml, you are giving 1 milliequal. All right. Every ml of soda bic, 8.5% equals 1 milliequal. So if you had a 50 kilo patient, you would give them 50 mils of 8.5%. So what if you only had 4%? Then you would give 100 mils because you're giving half a milliequal per ml. All right, so that's how you remember it. Okay, so for anything where you have to give sodium bicarbonate, remember the common dose of sodium bicarbonate is 1 milliequal per kilo. 2 milliequals if you're trying to what you call treat poisonings and that, but essentially 8.5%, 1 ml is equal to 1 milliequal. 4%, 1 ml is equal to half a milliequal. Okay. And then what you're aiming now, you're not trying to put the patient into a massive alkalosis. You're just trying to get the patient to about 7.45 to 7.55. All right. And then once you know for sure that it is anticholinergic poisoning, you kind of have a history, things like that, then you can give physostigmine as well. Okay. So now we're not doing ECG analysis today, don't stress, okay? But I just wanted to show you guys what and how much of value an ECG has in a patient who's got poisoning and how it can even give you a clue as to what's going on, right? So this one here is quite typical of TCA toxicity. And in fact, any patient that comes in poisoned, your ECG is one of the first things that you run, all right? So without going into a deep analysis, does it look normal? Of course not. Okay, it does look abnormal. Now, there's a few things that you can pick out from here. Number one, the tachycardia. Okay, so this is going at just over 100 beats per minute. Okay, so you don't have too much in terms of change of axis. You don't. The main things are rhythm abnormalities that you have and rate abnormalities. So the thing that you notice over here with the rhythm, what else do you see? P waves seem to have disappeared. Agreed. So it's quite a fast tachycardia, but it's a tachycardia that's also got sort of what looks like a left bundle branch block. All right. So now, if you see something like this in a poisoned patient, your mind has to start thinking about what's causing this. Okay. Now, the reason for why you are getting this sort of like a bundle branch block is actually those sodium channels. Okay. So sodium is required for an action potential to occur. Okay. And you have two types of sodium channels. Now, if you don't remember this, don't stress about it. It's just for your information. You have cardiac fast sodium channels and you have cardiac slow sodium channels. All right. And TCAs tend to affect the fast sodium channels. So the fast sodium channels are those ones that can exchange sodium quickly. So instead, what you have is exchange of sodium happening more slowly. So all of your repolarizations, depolarizations, everything's taking place at a much slower rate than what it normally should. Okay, even though your patient is tachycardic at the same time. I know it's a bit of a misnomer, but that's exactly what happens. All right. Now, even though this is quite typical, the most common thing to see in TCA overdoses is a QT prolongation. Right? So if you look at this interval from the QRS complex to the T, it's quite prolonged. So that's the most common thing to see, along with the tachycardia. And then I want you to notice this on AVR. Can you see this little pattern that sort of is forming over here? All right. This is probably the most common thing that you see, because this is where your sodium channels actually cause the most amount of, or let's say where you can see it the best. Because normally left bundle branch blocks, they could be pre-existing. There's a lot of things that could happen. But AVR generally is left unaffected, all right, in most ECGs, even with left bundle branch blocks, right bundle branch blocks, things like that. So what you get is the slurring. So you notice it starts off normally, then as it's trying to repolarize, it just kind of slurs along. And once you see that, that's tricyclic antidepressants or atropine. Okay, so even if you remember nothing else from today, if you remember AVR in an overdose patient that has a slur, this is most likely amitriptyline. If you can remember that, you'll save a lot of lives. Okay, so that's normally what you see. Okay, so as it gets worse, okay, this is as your cardiotoxicity starts to get worse. Can you see what's happening? This is almost looking like a hyperkalemia type of picture. Okay, so the QRS start getting broader, and like I say, it actually starts looking like hyperkalemia. But if you see this picture, this is quite a severe anticholinergic response that the patient is experiencing. Okay, so by this stage, the patient is on the verge of fibrillating and dying. Okay, so you've got to start treating this patient quite quickly. Okay, and then as you start treating the patient, then you start going back to normal. Okay. Okay, so you can see they talk about hyperventilation as well. We don't really have the resources to hyperventilate a patient for that amount of time. You have to physically hyperventilate a patient, for example, in our A&E. Okay, so the patient has had serum alkalinization, sodium bicarbonate, intubation, hyperventilation, and you can see that everything's returned back to normal. Most importantly, AVR. Okay, so I'm going to say one more time. Remember this. If you forget everything else that I say today, just remember this. Okay, when patients come in, you don't know what's going on, do an ECG. All right. This doesn't mean your ECG only looks for tricyclic antidepressants, but it tells you whether there is an overdose of some sort of substance. Because the most common things that will happen is a prolongation of your QT, what you call it, your QT distance. All right. When that happens, start thinking that this is an overdose, especially in an unconscious patient where you don't have a clear history, things like that. And specifically where you see the slurring in AVR, there you really got to start thinking, okay, this could be amitriptyline tricyclic antidepressants. Okay, so that's how you have a look at it. Okay, so this is just to show you what happens with those sodium channels as well. All right, so this is also typical of what it looks like. Physostigmine, if you can give it, and then sodium bicarbonate, as you can see, 1 milli equal a ml. Okay, so we've covered that. What about activated charcoal? All right, do you guys use it? Have you used it before? No, haven't used it. Okay, all right. So the first thing is that's exactly what it tastes like, all right? It tastes like farts wrapped in feet. Okay, it's horrible. Okay, it really, really is horrible. Okay, so how does it work? That's the question, right? How does activated charcoal work? Activated charcoal works similar to a process like chelation, right? Where basically what it does is it tries to absorb as much of whatever's in the gastric area or whatever's in the stomach. It just basically grabs it and pulls it in, all right? That's a simple way of understanding it, all right? And then it's enhanced elimination of that substance. So in other words, what you're saying is I've taken something, I've overdosed on it, I've taken 20 tablets. By giving activated charcoal, if it absorbs 14 of those tablets, now I've got an overdose of 6 tablets compared to 20. All right, so that's basically what activated charcoal is doing. So where does it grab the stuff? In the stomach. It doesn't grab it in the intestine. So that means it's very dependent on time. Because as soon as gastric emptying occurs, it's no longer that effective. Okay, so gastric emptying normally occurs after 1 hour. Up to 4 hours, all right? So you need to give activated charcoal within 1 hour of an overdose happening, okay? But you can give it up to 4 hours later, right? And we have done it, and it has worked, all right? And you can use it. There's nothing wrong with using activated charcoal, but there's a few provisos, okay? So what are the indications for activated charcoal? Patient is awake, all right? When we say that, your patient can't be like GCS 13, 14, confused, possibility of aspiration. That's what we're trying to say. So your patient has to be awake and your patient has to be able to swallow it. Alternatively, your patient is intubated and has a properly placed, nasogastric tube. All right. So what do you do if your patient is GCS 13, 14, 15, 13, 12, 13, 14, and you still need to give them activated charcoal? Can you give it to them? Okay. You can, but you have to put a nasogastric tube, all right? Have you tried to put a nasogastric tube in somebody with a GCS of 13? It's not fun, huh? It's not fun, okay. So if you suspect a severe overdose, rather intubate the patient, all right? Sedate, muscle relaxation, but that's a difficult thing because these patients are already under the influence of some substance. Now you're going to put them under the influence of another substance. Okay? So in those cases, try not to rush to give activated charcoal because there are other things that you do. For example, sodium bicarbonate. You can give the antidote for that specific toxin if you know what it is, all right? But sometimes we don't. The other thing with activated charcoal, the patient can't have had any sort of corrosive substance. So what are corrosive substances that you know? All the kids tend, potassium permanganate, very good. So that's a very common one. Any sort of jig, bleach, anything like that. The reason being, again, aspiration and leakage, all right? Bowel ileus, all right? because it's not going to do anything. It's just going to sit over there. GIT perforations, because you don't want the activated charcoal to leak into the abdomen, all right? And like I say, ideally, it should be given within 1 hour of ingestion. But like I say, we have used it up to 4 hours later, but with mixed results, okay? So when your patient is going to take it, you have your GCS 15 patient who took 20 Panado tablets, is perfectly awake. First thing you need to do is warn them. This thing is going to taste horrible, absolutely terrible. They need to down it as quickly as they can. Because if they sip it, they're not going to get through it, all right? So they need to be able to take it, all right? And it's quite a large amount. It's about 50 grams. So it's a nice big amount of powder that you've got to mix with water. It stinks, all right? It's not the worst thing that you could ever have. I've smelled some vodkas that smell a bit worse than it. But what I'm saying, it doesn't smell nice. It doesn't taste nice. And, and the problem with activated charcoal is that if you suspect you are going to intubate later, it's not a good idea to give it because it kind of coats everything. Everything becomes black on the inside, okay? So if you're now going to try and intubate after that, you're going to have this throat that's completely, dark. You're not going to be able to see anything. So you must be very careful when you use it, especially if you suspect your patient is going to get worse. You rather intubate them first and then give the activated charcoal via the nasogastric tube. Okay, so that's activated charcoal. Okay, so let's have a look at some more. All right, so we look at some more toxidromes. All right, let's have a look at opioids. All right, so what are our common opioids that we know? Common opioids that we use. All right, morphine, pethidine, but what's more common amongst our patients? It's a synthetic opioid that we give out for pain all the time. Tramadol, very good. All right. So tramadol, we all give it these days. We love to give it. Okay. So the problem with tramadol is what they call a dirty opiate. All right. It's a synthetic opiate, highly addictive. All right. And the problem is that it's easily obtainable, relatively speaking. I mean, you can't walk into a hospital and ask for morphine. Have you given a script for morphine? Even if you write it out correctly, the pharmacist still sends it back and says, no, you forgot a comma here. You didn't write. I mean, you can't make out it's O-N. Is that an E for one or did you put a T? You get what I'm saying? So morphine is not easy. Pethidine is highly controlled. But tramadol is given out relatively easily. All right. So what happens is patients do become addicted to it. And the problem with tramadol is that the effect that the patient has decreases with time. So they need to increase the amount of intake that they are taking and things like that. But what do opioids do? Why are opioids so effective? Why are they so good at killing pain? What do? They tell the brain, chill, relax, there's nothing happening, don't worry. That's basically what an opioid does, all right? So if you study pain, pain has the pathophysiology of pain is quite interesting. But to basically put it, so you have your nociceptors in the skin. Then you have chemical receptors, a chemical release and chemical receptors that are working. And then you have central pain, all right? So in other words, where does substance P and all of that go is into the central brain. So opioids go to the central brain and tell the central brain, sorry, there's no substance P, there's no nociotoxins, there's nothing that's coming there. So don't stress, everything's fine. And that's why it switches off pain. But the problem is it doesn't only switch off pain, it switches off a few other things. It decreases your levels of cortisol. It decreases your levels of adrenaline. It decreases everything. And that's basically what it does. It tells the body to chill out. And in high enough dosages, it starts affecting the midbrain. And the midbrain controls respiration and heart rate, blood pressure, all of those things. So even before we go into the toxidrome, what do you expect to see in a patient who's overdosed on opioids? First of all, level of consciousness. Decreased. Mildly or significantly? Significantly, all right, because that's the whole job of the opioid, all right. What do you expect their blood pressure to be? Low. Their heart rate? Low. Their breath rate or breathing rate? Low, because everything's just basically shutting down. Okay, that's basically what's happening. So this patient has voluntarily tried to turn their brain off for whatever reason, okay. So slow pulse, slow breathing rate. Patient becomes progressively more comatose. The pupils become pinpoint. Okay, so you'll notice in toxicology, pupils are extremely important. Before you do anything else, look at the eyes. Dilation, fixation, pinpoints, all of these things, they can point you in a lot of directions as to what is going on, all right? They are the windows to the soul. Okay. So how do you manage it? Naloxone, Narcan, all right? Have you guys followed the opioid crisis in America recently? All right, if you have a chance, go and read up about it. All right, so it was quite amazing. There's a drug they call Vicodin. You guys watched House? That's what House used to call Vicodin. All right, so Vicodin was being pumped into the American health system by the drug companies, okay? And they were pumping huge amounts of it. And they put out all of these public service announcements and adverts to say that opioids have no side effects, you don't have to worry about it. They had patients like coming on and saying how amazing they were feeling, their back pains were gone, everything was gone. So patients were taking opioids and starting to get addicted and starting to take more and more and more and more. And it's an ongoing crisis. So if you go to the States and you find a paramedic or you find a fireman or you find a cop, they'll have this little bottle on the side of their hip, and it's naloxone in a spray form. All right. So anytime they find anybody unconscious, they immediately go and spray what they call Narcan. All right, naloxone. They spray Narcan in their noses to try and wake them up and try and combat the opioid. All right. So how does naloxone work? Naloxone is a competitive antagonist. It basically goes to the same receptors that the opioids go to, and it blocks them off. Okay. So how do you give it? You give it, but you give it titrated. Okay. What does that mean, titrated? You normally have naloxone in a single vial. Okay. The problem with naloxone is that naloxone is very quick acting and opioids are very long lasting. Okay, we're going to stop here, don't worry. Okay. So if you give all your naloxone at one point, your patient will immediately improve, but after 15 to 20 minutes, they're just going to drop again. All right. So that's your problem with opioids, and that's your problem with naloxone or Narcan, whatever you want to call it. So your naloxone normally comes in a single vial of 1 milliliter. You take that 1 milliliter, mix it with 3 milliliters of water. So you get 4 mils altogether. Each mil contains 0.25 milligrams of naloxone. And you give that every 15 minutes, 1 mil every 15 minutes. All right. 0.25 is enough to act as an antagonist to any amount of opioids that you may have. All right. And you have to keep on doing it. All right. So do these patients then, once they're feeling better, go to the ward? No, they have to go to ICU. All right. The reason being, what happens if they've taken 30 tramadols, 40 tramadols, 50 tramadols? That's not going to come out of their system after you've given 4 or 5 doses of naloxone. They may need recurrent doses of naloxone in order to come out of it. All right. So at some tertiary centers, they have stopped using it, or they're only using it under consultant supervision. I'm not sure why. It's quite an easy thing to use. But just in case one of you ends up at an area where they say, naloxone, how dare you? You must understand, some places they really are using it like that. I'm not sure why. I think the main reason why they're doing that is because some people have the habit of just giving the whole vial. Patient wakes up, everything's fine. You go to the next patient and you carry on, and 15 minutes later, that patient is dead. Okay, so now you know what opioids do. Okay, so this means you can do this to patients with morphine, and you can do this to patients with ethidine as well, or iatrogenic overdose. So you need to be careful of those as well. So if you are giving a patient opioids, keep an eye on what's going on. But it has some beneficial effects as well. So if your patient has high BPs and is anxious, give them a bit of morphine. They'll chill out. Seriously. And you'll see their BPs will drop as well. Patients having severe pain with high blood pressure, give them pethidine. Everything kind of chills out, settles down, and you'll notice their BP settle down and everything goes well. But if your patient is already a polytrauma patient, the BP of 70 over 40, do not give them too many opioids because they will immediately crash. All right. If your patient comes in with another overdose and has low BPs, do not give them opioids in order to alleviate pain because you will decrease. All right. We're going to cover toxinology, snake bites, scorpion bites, and things like that. And you'll see they also tell you to avoid opioids for the simple reason that it drops BPs as well. Okay. So you just have to be careful of that. So what we'll do, yeah, there we go. All right, so that's the whole thing. All right, so that's how we kind of give it. So you wait for your respiratory rate, heart rate, everything to kind of normalize, and then you see how it happens. So one of the problems is that if you give too much of it too quickly, you can get an acute opioid withdrawal syndrome as well. All right. So what happens is your patient becomes nauseous, your patient becomes agitated, your patient becomes restless, aggressive, things like that. All right. So in other words, the complete opposite of being chilled out, they become hypomanic, if I can put it that way. BP starts shooting up, respiratory rate through the roof, you know, things like that. So you're trying also to avoid that by giving it in this manner. Okay. So yeah, I think we'll kind of stop there because the next one is sympathomimetics, and we'll kind of finish off next week. Okay, okay, great. All right. But any questions or anything like that in the meantime? So do you guys understand opioids and tricyclics? Okay. So these are the reason why I've concentrated on these so far is because these are the patients who come in unconscious. Okay. The other patients that tend to come in, we will cover them a little bit later, like paracetamols and antibiotics and ARVs and all. But those are generally patients that are awake and talking, so they tell you what they took. Right? So we'll cover some sympathomimetics next week, okay, and try and finish off a little bit more. But any questions? Anything I'm not sure about? As I always say, it can be difficult, right? Toxicology, toxinology is a whole 3-year course that you can do and become a super specialist. So there's a lot. There's a reason why we have a toxic center at your phone, or poison centers, because there's so many, and there can be so many varying effects and things like that. So when you get that patient, the first thing is try and see, is this something that I recognize? If it's not something that I recognize, let me ask for help. If it's something that I recognize but I've forgotten how to treat, let me check it up as well. All right. But hopefully you guys will get the hang of it. Okay. All right. So we'll carry on next week. And then, yeah, if there are any questions, you can always ask me a bit later. Okay, thanks.